Welcome to another AsiaMed video, and this is another of the videos on the Airway Pressure Release Ventilation series. And in this video we're going to be talking about how to wean a patient off APRV, specifically thinking about how to manage a patient with resolving hypoxia. We'll talk a little bit about the physiology of APRV and what it is, and then really think about what settings we can change for a patient whose hypoxia is getting better over time. And before we talk about that, it's worth thinking a little bit about what oxygenation depends upon. Now, if you're watching this video without having seen any of my other videos, I'd really recommend going through the videos on basic ventilation first, and then the first few videos on APRV. But essentially, oxygenation depends upon the fractional inspired concentration of oxygen, which is quite obvious, and over time this is probably one of the first things that people will wean down. Once this is weaned down, it's always worth thinking about which alveolar units are open. The more alveolar units that are open, the better the oxygenation, and that is really the premise behind giving patient positive pressure ventilation, i.e. intubating them. Alveolar blood flow is something that is often forgotten, and improving a patient's cardiac output and reducing the amount of pulmonary vascular resistance is vital to maximizing a patient's oxygenation ability. And the final thing is improving the alveolar blood interface. This is often the reason why patients are hypoxic when they come to intensive care. And usually it's a matter of reducing the amount of fluid on the lungs, especially if they've got left ventricular failure and pulmonary edema, or by reducing the amount of infection through giving patients antibiotics and clearing the chest with chest physio. Carbon dioxide usually depends upon two things: the minute ventilation, which is dependent upon the tidal volume and the respiratory rate, and alveolar perfusion, as with oxygenation. In APRV, we talked about the fact that diffusion of CO2 is actually also an important concept. By having a continuous pressure throughout, you're going to hopefully maintain a continuous conduit of gas or a column of gas from the endotracheal tube through to the alveolar units. Therefore, as the alveolar units fill up with a high concentration of CO2, it'll then diffuse passively through a concentration gradient down through the lungs, through the endotracheal tube, and into the ventilator. And therefore, you find that you can improve the CO2 clearance purely by keeping the whole airway open throughout the respiratory cycle. APRV, as we mentioned previously, is considered an extreme form of CPAP. What you're trying to do is to use a high pressure to maintain alveolar recruitment throughout the respiratory cycle. And by using those high pressures, we're splinting open those alveoli that are being crushed either by abdominal contents or mediastinal contents pressing down on them, or through inflammation and thickening of the alveolar walls, as happens in many disease processes of the lung causing hypoxia. An important concept is that of a lung compliance. If you imagine a balloon that is being blown up, it's really difficult to blow that balloon up at the start, but then once you've got to a certain point, suddenly, with each breath, the balloon expands up that much more easily, until you get to a point where it is so full that again it becomes very difficult to expand up the balloon anymore till it pops. And that's what we're trying to do with our patients. We want to try and get them to the point where it's easy to inflate and deflate the lungs, i.e. if you look at this graph, you want to get to above the lower inflection point and below the upper inflection point, in that part of the curve where just a small change in pressure causes a large change in volume. That is where the lung is most compliant. As lungs become more diseased, thick, heavy, soggy, they become less compliant, and therefore you need a higher pressure, beginning pressure, in order to be able to open up the lungs. And that is where the peak high pressure in APRV becomes very useful. You want to try and keep that pressure at a level where if the patient needs to breathe, they're able to do so comfortably. And so you want to be within that compliance range of between the lower and upper inflection point. And by doing so, you can improve the patient's ventilation, but also oxygenation. So as the lungs start to improve, you may well find that you can reduce down your pre-high or your pressure high, because actually their compliance is improved, and so for the same amount of pressure, you get more expansion of the lungs. APRV is mainly about trying to keep that high pressure for as long as possible, but the detriment to that is that you get build-up of CO2 despite that passive diffusion, and that's where you need the releases. And what the releases do is they allow bulk flow of gas out of the lungs and therefore removal of CO2. This is akin to taking a breath out in normal ventilation or in spontaneous breathing. So, what are the things that we can set in APRV? Well, for the most part, the things that we can set are the fractional inspired concentration of oxygen, as you would do with any ventilator. Also, the high pressure that you're maintaining a patient at, and the amount of time that it's at the high pressure. The low pressure is almost always set at 0, or as close to 0 as the ventilator will allow. And then you have a very short low time. That's the time that it's maintained at that low pressure. The low pressure is the release phase of ventilation, and therefore the time where you get the bulk flow of gas coming out. So as hypoxia resolves, the first thing that you're going to be doing is dropping down the fractional inspired concentration of oxygen. Once you get to below 50% for most people, you would then be looking to try and reduce down the pressure. And so this is the high pressure. The reason for that is, firstly, the compliance of the lungs are improving. So now, rather than being in the middle of the compliance curve, you've gone up towards the higher inflection point. And so by reducing the pressure, you reduce it down and so allow the patient to easily breathe in and out. If you imagine you're driving at 70 miles an hour, you stick your head out the window of the car, you suddenly find that your lungs overexpand. It can be quite difficult to breathe, and so it can be difficult to wean patients if they're at too high a pressure and their lung compliance is improved. So once you reduce down the pressure, you're hoping that the lung alveolar units will remain open, that the disease state is reduced, and therefore you need less pressure to maintain those alveoli open. So you can start to wean down the pressure high. And this is the concept of patients being weaned off APRV. You will hear about drop and stretch. What you're talking about is dropping down the pressure high and then extending out the time that you've got the high pressure, the P high. And the reason for doing this is effectively what you're coming down to is just effectively CPAP, where in CPAP you just have a positive end expiratory pressure and you have no releases. And then at that point you can look to extubating this patient if you choose to stay in APRV mode. So when thinking about improving hypoxia, what you want to try and do is to keep the FiO2 as low as possible. Above 60%, we know it's definitely toxic to the lungs, but probably any oxygen level higher than 21 to 30% is probably bad for the lungs. And therefore, as soon as you get to below 50%, you should be thinking about reducing down the other parameters. Above 50%, the most important thing is to try and bring the fractional inspired concentration of oxygen down. You want to always be cognizant of the patient's compliance. As their disease state improves, their compliance will improve. And so as that happens, you want to try and make sure you don't get too far off the compliance curve, either below the low inflection point or above the high inflection point. and as such you want to try and maintain the perfect level, and that usually translates to reducing the pressure high time and the pressure high amount as much as possible. And this comes back to that concept of the drop and stretch. Drop the pressure high and increase the time that it's at the high pressure longer and longer till you get rid of all the releases, and your pressure high comes down to a reasonable level of 5, 8 or 10 centimeters of water. That's the end of the talk. Thank you very much for your time. If you like this video, please like and subscribe, and hit the bell notification for any new videos that are coming out.